Let's start with miliaria. These are due to obstruction of sweat glands, otherwise known as eccrine ducts, and they're common in hot and humid environments and present with varying morphologies, ranging from vesicles to papules, pustules, and nodules. Folliculitis is due to an inflammatory follicular reaction either to bacteria or yeast, and these are typically monomorphic, that is, they are in one generation of lesions, as opposed to acne, which comes in multiple generations. Importantly, in folliculitis, there are no comedones. Pseudofolliculitis barbae, otherwise known as ingrown hairs, are specific to the areas of the facial region with hair-bearing sites, so beard regions, especially in men, and typically these are due to a foreign body inflammatory reaction from the insertion of the end of the hair shaft into the epidermis. So they're fairly easy to detect if they are looked for with the incurled hair.
Gram-negative folliculitis is a pustular rash resembling acne. It can be developed especially in relation to prior antibiotic use. Gram-negative folliculitis cannot be diagnosed by visualization, but rather is determined by testing based on a bacterial culture.
Rosacea-form dermatoses have this background classical centrofacial erythema with possibly papules and pustules. Its variant perioral dermatitis has a perioral distribution, but importantly, there are no comedones. Sebaceous hyperplasia can look like inflammatory papules, but on closer appearance, they are actually not red. They're more pink, yellow, or pink-orange, and have lobules with a central invagination. Keratosis pilaris faciae has prominent follicular orifices with this background erythema. It's a hereditary condition and often also seen on the upper aspects of the arms as well as the upper back. Syringomas at first appearance may look like comedones, but on closer appearance they look like almost comma-shaped flesh-colored papules, and they are due to benign eccrine tumors. Black dot hair follicles develop primarily on patients with darker hair and light background skin and are primarily a normal variant of larger pilosebaceous units at the nose, and they are not open comedones.
Trichostasis spinulosa predominantly affects the nasal skin of adults and is often confused with open comedones. It can occur in both men and women, but is rarely observed in children and is uncommon during adolescence. Lesions appear as open pores filled with multiple tiny short hairs, usually only visible with a magnifying glass. Each follicular plug results from hyperkeratosis, may contain 5 to 25 vellus hairs, and is usually about 1 millimeter in size. The trapped hairs make the pore appear dark, hence the similarity to blackheads and black dot follicles. It is important to note the key distinguishing factor between trichostasis spinulosa and black dot follicles are the number of vellus hairs. Black dot follicles present with a single vellus hair, whereas trichostasis spinulosa presents with multiple vellus hairs. It is possible for a patient with light hair to present with white dot follicles. The photo on your screen is an example of trichostasis spinulosa presenting with white dot follicles, as this patient has fair skin and light hair. Milia are raised, small, pearly white or yellowish bumps on the skin. Clinically, they represent keratin-filled cysts. They are most often seen on the upper cheeks, just below the eye, but can occur at other sites as well. They are well demarcated and are somewhat more elevated than comedones. They typically occur in clusters and can be confused with closed comedones.